We often hear modern cancer treatments described like high-tech sniper rifles, like they're laser focused.
Right.
The beam just hits the tumor, shatters the bad cells, and supposedly leaves everything else perfectly intact.
It's a very comforting illusion, certainly. I mean, when you're sitting in an oncologist's office facing a terrifying diagnosis, you want to believe the collateral damage will be zero.
Totally. You just want it to be isolated.
Exactly. You want to believe the intervention is, entirely contained.
But then you actually look at the clinical data regarding what happens inside the female pelvis during radiation, and that sniper rifle analogy completely falls apart.
Oh, absolutely. It really does.
The machine turns off, you're declared cancer-free, but your internal, microscopic landscape has basically just been hit by an earthquake.
And rebuilding after an earthquake requires understanding that the ground itself has fundamentally shifted.
Yeah.
We're looking at a cascade of biological, structural, and hormonal changes that alters a woman's body long after the cancer is actually eradicated.
Welcome to the deep dive. Today, we are exploring a really vital, yet honestly entirely under-discussed aspect of cancer survivorship. We're looking at exactly how pelvic radiation treatments impact a woman's ovarian function and vaginal tissue health.
Such an important topic.
It really is.
Yeah.
And we are pulling from a massive stack of material today to shortcut your journey. We've got clinical guidelines from the British Gynecological Cancer Society and the British Menopause Society, plus patient care guides from the Royal Marsden, Royal Berkshire NHS Trusts, Macmillan Cancer Support, Cancer Research UK, and a really pivotal PubMed clinical review by I.D. White.
That's a great stack of resources.
Yeah, our mission is to give you the biological why behind these changes and, more importantly, the tools available to reclaim that physical and sexual well-being.
Oh, okay. Let's unpack this. We need to start at the biological engine room of female hormones, which is the ovaries. Because what happens there essentially creates the shock wave for everything else, right? It does. If a woman undergoes pelvic radiotherapy, which, is standard protocol for many cervical, womb, vaginal, or anal cancers, those radiation beams are passing right through the pelvic cavity.
And the ovaries are just sitting right there.
Exactly. They sit right in the middle of that highly trafficked real estate. So the direct result of that radiation exposure is something called premature ovarian insufficiency, or POI.
Which is essentially an early medically induced menopause.
Yes, exactly.
But I want to understand the mechanics here a bit better. If the radiation is targeting a specific cancer, say on the cervix, why do the ovaries automatically shut down? Is it basically collateral damage, like knocking out the power grid to the whole factory just to fix one machine?
That is a great way to put it. It comes down to how radiation fundamentally works. It destroys cancer by causing double-strand DNA breaks in rapidly dividing cells. But it isn't smart enough to only target cancer cells, right? It targets anything in the radiation field. And because it's a regional treatment aimed at eradicating microscopic cells that might have migrated away from the primary tumor, the entire pelvic area is irradiated.
The power grid just goes down.
Precisely. And ovarian follicles, those tiny sacs that hold a woman's eggs, they are incredibly sensitive to radiation. Even relatively low doses will cause irreversible DNA damage to those cells.
Wow.
Yeah, they stop producing eggs, and crucially, they stop manufacturing estrogen and progesterone. For treatments targeting womb cancer, this complete shutdown of hormone production isn't a maybe. It's a biological certainty.
Which makes the timing of medical interventions so critical, right? The guidelines from Guy's and St. Thomas Hospital strongly emphasize having fertility preservation conversations before a single beam of radiation is even fired.
Oh, absolutely. Once that DNA damage occurs, you can't undo it. That window of opportunity is minuscule.
Because patients are usually rushed right into treatment.
Right, but taking a moment to freeze eggs, embryos, or even cryopreserve a piece of ovarian tissue to potentially reimplant later is just vital.
I was actually reading through the Cancer Research UK files, and they mentioned a surgical option called ovarian transposition. And I have to admit, this stopped me in my tracks.
It's fascinating, isn't it?
It's wild. How do you just move an organ out of the way? Don't you sever its blood supply?
It's a remarkable piece of surgical engineering, honestly. Before radiotherapy begins, surgeons use keyhole surgery to physically detach the ovaries from their normal position in the pelvis and move them higher up into the abdomen.
That is just incredible.
And to your point about the blood supply, they don't sever it. They carefully mobilize the blood vessel, the ovarian pedicle, stretching it upward along with the ovary.
So they literally relocate the power generators to a safe zone above the radiation field.
Exactly. They pin them to the abdominal wall to try and preserve natural hormone function.
Okay, but for those who don't have that option, or maybe if the transposition fails, the resulting drop in hormones has to be intense. Because natural menopause usually happens gradually, over several years.
Right. The body slowly acclimates to the lower estrogen levels.
But radiation-induced POI is like flipping a switch in a split second.
The abruptness is really what makes it so brutal. The symptoms are often significantly more severe than a natural age-related menopause.
I can imagine.
Think about going from peak hormone production to zero in a matter of days. You're looking at intense hot flushes, drenching night sweats, profound mood destabilization.
And there are hidden dangers too, right?
Yes, exactly. Estrogen normally protects bone density. Without it, the body is suddenly at a vastly accelerated risk for bone thinning or osteoporosis.
And losing that systemic estrogen triggers a localized disaster as well, which leads us to the physical reality of the vaginal tissue itself.
Yeah.
You described this to me earlier as a double whammy.
Yes, the double whammy.
Let's break down exactly what that means.
So, the vagina is essentially under attack from two compounding forces at the exact same time. First, you have the systemic starvation we just talked about. Estrogen is the fuel that keeps the vaginal mucosa, the lining, thick, highly elastic, and naturally lubricated.
Right.
When you shut off the estrogen, that tissue naturally begins to atrophy. It thins out and loses its moisture. But then you add the second force, which is the direct physical trauma from the radiation beams passing right through that tissue.
I really want to visualize what that trauma actually looks like at a cellular level.
Yeah.
Because it's not just, a little dryness.
No, not at all. What's fascinating here is how the body responds to that trauma. Radiation actively triggers a massive inflammatory cascade.
Like an injury response.
Exactly. The body registers the radiation damage as a profound injury, so it sends in these cells called fibroblasts to repair the area. But fibroblasts don't rebuild healthy, stretchy mucosal tissue. No, they lay down collagen. They build scar tissue. This process is called fibrosis. At the same time, the tiny microscopic blood vessels in the vaginal walls become damaged, which drastically reduces blood flow to the area.
So you have this combination of dense, inflexible scar tissue and a lack of blood supply. It sounds like a rubber band that's been left out in the blazing sun for a month.
That's a good way to picture it.
Like it loses its natural stretch, it dries out, and if you try to pull it, it just becomes brittle and snaps.
It's a great visual for the loss of elasticity, but it's actually even more complicated than a rubber band.
How so?
Well, a rubber band just loses moisture and degrades passively. In the human body, this is an active, aggressive process. Fibrosis is active scar tissue pulling the vaginal walls together, which leads to something called stenosis, a physical narrowing and shortening of the canal.
Right, really. It actually physically shrinks.
Yes. Up to a third of patients develop vaginal stenosis. And because the skin inside the vagina is now paper thin from the lack of estrogen, it is incredibly fragile. It doesn't just lose its stretch, it actively tears.
Wow. And reading through the Macmillan and Royal Marsden patient guides, those tears are not minor irritations at all. They describe painful ulcers, severe inflammation known as vaginitis, and, significant bleeding.
The bleeding is incredibly distressing. Just imagine you're a patient who has just survived a harrowing cancer treatment. You go to the bathroom or you attempt physical intimacy and there is sudden bleeding.
The immediate terror would just be the cancer is back.
Exactly. The psychological impact is huge. But what's actually happening is that the fragile, compromised blood vessels near the surface of that thin tissue are just breaking open from minimal friction.
The sources mention doctors sometimes using a chemical called silver nitrate to treat this. How does that even work? Are they basically painting a chemical onto an open wound?
Essentially, yes, though it's highly targeted. Silver nitrate is a chemical cauterizing agent. When it's applied to a bleeding microscopic vessel, it creates an immediate chemical burn. This triggers an instant scab and eschar that physically plugs the bleeding vessel.
Ouch.
It seals the area so it can heal, but it really highlights just how delicate and damaged this tissue has become.
It paints a stark, intense picture of what patients are dealing with behind closed doors. You've got tissues that are physically shrinking, scarring, and tearing. So logically, to fix the thinning and the dryness, you need to replace the missing hormones.
Right.
You have to get the estrogen back in there. But the moment you bring up hormones in a post-cancer context, you hit a massive wall of fear.
It is arguably the biggest hurdle in survivorship care today. For decades, the dominant medical narrative has been that hormones, particularly estrogen, are fuel for cancer.
Right, that's what everyone hears.
So many women, and quite frankly, a concerning number of healthcare providers, are deeply terrified of using hormone replacement therapy, or HRT, after any kind of cancer diagnosis.
Okay, I want to challenge this because I know exactly what the listener is thinking right now. You're telling me we are supposed to take estrogen, the exact hormone known to feed certain reproductive cancers, and intentionally put it back into the body of a cancer survivor. How is that remotely safe?
That is the exact instinct most people have, and it's totally understandable. But we have to look at the nuance of the clinical data here. The guidelines from the British Gynecological Cancer Society push back hard against this blanket fear.
All right.
They explicitly state that having a gynecological malignancy is not an automatic across-the-board ban on HRT. You really have to look at the specific type of tumor.
So not all cancers have estrogen receptors.
Exactly. Unless a patient had a highly hormone-sensitive cancer, like certain advanced stages of low-grade serous ovarian cancer or endometrial stromal sarcoma, the tumor isn't necessarily going to use estrogen as fuel.
I see.
For the majority of women, the clinical consensus is that the benefits of systemic HRT far outweigh the theoretical risks.
And when you say systemic HRT, you mean the pill, patch, or gel that puts estrogen into the entire bloodstream.
Yes. Systemic HRT treats the severe whole-body symptoms. It stops the intense hot flushes, it stabilizes the mood, and crucially, it provides that massive protection against pelvic bone fractures that we mentioned earlier.
Okay, but what about the women who absolutely cannot take systemic HRT? Say a patient who had a highly estrogen receptor positive breast cancer who later required pelvic radiation for a different issue. Their oncologist is never going to sign off on an estrogen patch, right?
No, they wouldn't. And this is where the medical nuance becomes truly life-changing.
Okay.
For those women, there is a localized solution that is incredibly safe, and that's vaginal estrogens. We're talking about creams, small tablets called pessaries, or flexible silicone rings that are inserted directly into the vagina.
Here's where it gets really interesting, because the reason these are deemed safe is all about the dosage and the delivery mechanism, right?
Yes, exactly.
There is a statistic in the clinical guidelines that absolutely blew my mind. The total administered dose of modern vaginal estrogen over an entire year, an entire 365 days of treatment, equals just one single systemic pill.
It is a microscopic amount of hormone, and the safety really lies in the pharmacokinetics, how the drug actually moves through the body.
Right.
Let's use an analogy. Imagine you have a single, dying, dehydrated plant in your garden. Taking a systemic HRT pill is like flooding the town's entire water supply, hoping enough water makes it to that one specific garden bed.
Because it has to go everywhere else first.
Right. You have to use a massive dose because the pill has to survive the digestive tract, get processed by the liver, and circulate through the entire circulatory system.
But localized estrogen is entirely different.
Exactly. Localized vaginal estrogen is like taking a tiny eyedropper of water and placing it directly onto the roots of that one dying plant. You are applying a microdose directly to the damaged tissue.
So it absorbs locally, but it doesn't spike the estrogen levels in the rest of the body.
Right. It binds locally to the estrogen receptors situated right there in the vaginal mucosa. It signals the tissue to thicken, restores the local blood flow, and brings back the natural moisture.
That's amazing.
And the systemic absorption, meaning the amount of estrogen that escapes the pelvis and makes it into the general bloodstream, is clinically negligible. It stays almost entirely local.
Wow.
This is why the guidelines stress that vaginal estrogens are safe for the vast majority of women, directly counteracting that persistent fear.
Okay, so the local estrogen eyedropper can essentially re-moisturize and plump up that tissue. It fixes the biological environment. But an eyedropper of water isn't going to dissolve physical scar tissue?
No, it won't.
Like it can't magically undo the dense collagen fibrosis that we talked about earlier?
Not at all. Hormones handle the biology, but fibrosis is a structural engineering problem. If the vaginal walls are physically adhering to each other or shrinking due to scar tissue, hormones alone won't pull them apart. You need a mechanical solution to maintain the spatial volume and the elasticity.
Which introduces the physical interventions, specifically vaginal dilators.
Yes.
And when you first hear about them, the concept sounds incredibly clinical and, frankly, a bit daunting. The Royal Berkshire Patient Guide describes them as plastic or silicone tampon-shaped cones that come in sets of graduating sizes.
They are purely mechanical medical devices. Their sole purpose is to stretch the vaginal walls and prevent those fibrotic adhesions from cementing together.
Right.
But it's not just about pushing the scar tissue away. It's about something called mechanotransduction.
Mechanotransduction. Break that down for me.
Sure. If we connect this to the bigger picture, it's how cells actually respond to physical tension. When you mechanically stretch the tissue with a dilator, you are sending physical signals to the fibroblasts in the area.
I see.
You're essentially telling them, we need this tissue to remain flexible. Do not lay down dense, rigid collagen here.
That makes so much sense. So it's not just like putting a shoe tree into a leather shoe to stop it from shrinking as it dries.
No, a shoe tree is just a passive placeholder.
Right. This is an active cellular communication.
Okay.
You are physically training the tissue to remember its capacity to expand.
That is a brilliant way to frame it. You are forcing the cellular memory to maintain flexibility. But the protocol requires intense dedication. The clinical advice is to start using the dilators about 2 to 4 weeks after the radiation therapy ends.
But pretty soon after.
Yes. You have to allow the acute, raw inflammation to settle down, but you cannot wait too long, or the fibrosis begins to set in permanently.
And the routine they outline is rigorous. Patients are advised to use them for 5 to 10 minutes, initially 3 times a week, or sometimes even daily, and always with a water-based or silicone-based lubricant. The guys are very specific. Never use oil-based lubricants if you're using anything latex, as the oil literally degrades the latex.
Exactly. Consistency is everything here. If you don't provide that regular mechanical stretching, the fibrosis will dictate the shape of the anatomy, leading to severe stenosis.
But the sources also point out some surprising, and frankly much more human, alternatives to the medical dilators. Both the Royal Berkshire and Macmillan guides explicitly note that using a vibrator or having regular penetrative sexual intercourse provides the exact same mechanical benefit.
Which is a crucial medical validation. Preserving this anatomy isn't just an anatomical exercise, so doctors can comfortably perform follow-up speculum exams to monitor for cancer recurrence, though, that is undeniably critical.
Of course.
Fundamentally, this is about preserving the patient's capacity for physical intimacy and their overall quality of life.
But fixing the tissue mechanically doesn't automatically fix the mental toll. I mean, if a woman uses a dilator and heals her vaginal lining, she still has to navigate the psychological minefield of returning to physical intimacy.
Absolutely.
Because we aren't just talking about a biological mechanism in isolation here. We're talking about sexuality, relationships, and human identity.
And that is routinely the most devastating, overlooked casualty of cancer treatment. Macmillan estimates that 350,000 people in the UK alone experience sexual consequences from cancer treatment.
That is staggering.
It's an army of people suffering in silence, feeling completely alienated from their own bodies.
Because the changes aren't just about dryness or scar tissue. The actual anatomy of pleasure changes. We read about how the clitoris can lose blood supply or nerve sensitivity due to the localized radiation damage.
Yes.
And for women who've had their womb surgically removed as part of their treatment, the physical sensation of an orgasm can fundamentally alter because they no longer experience those specific uterine contractions. It's like the instrument you've played your whole life suddenly has completely different strings.
That's a profound way to look at it. And this is exactly why the clinical review by I.D. White published in PubMed is such a pivotal piece of literature.
Right, the biopsychosocial model.
Exactly. White strongly advocates that oncologists and care teams must adopt this integrated biopsychosocial model of care.
So what does this all mean? Basically that you can't just hand a patient a plastic dilator and say, good luck, see you in 6 months.
Precisely. You have to treat the whole human. The bio represents the physical reality, treating a stenosis, the lack of estrogen, the dyspareunia, which is the medical term for severe pain during sex.
Okay.
The psycho addresses the profound psychological weight. Imagine the loss of confidence, the altered body image, the grief over lost fertility, the fear that your body is now somehow broken.
And then the social is the relationship dynamic. How do you communicate this entirely new landscape to a partner without feeling overwhelming shame or inadequacy?
Exactly. You cannot effectively treat the physical pain of dyspareunia if the patient is gripping with psychological trauma and relationship strain. It all intertwines. The anxiety alone causes pelvic floor muscles to tense up, which makes the physical pain of intimacy exponentially worse.
Right. Imagine you're a patient who just survived months of grueling radiation. You think you're in the clear.
Yeah.
You survive. But now, the old ways of experiencing pleasure are incredibly painful, or they just feel completely absent. What does the biopsychosocial model actually ask these couples to do?
It demands a radical shift in communication and a complete redefinition of intimacy. Couples have to be willing to explore what feels good now in this new bodily landscape, rather than desperately chasing what used to feel good.
Right.
Maybe penetrative intercourse is off the table for a prolonged period, or maybe permanently. That does not mean a sexual, intimate relationship has to end. It means finding new ways to connect without the pressure of old expectations.
If 350,000 people are dealing with this in the UK alone, it begs the question, why is this still treated as a whispered taboo? Like, why are these holistic, psychosexual side effects so frequently ignored during routine post-cancer checkups?
This raises an important question, and it really points to a systemic failure of the traditional medical model. The traditional model focuses almost entirely on eradication and survival. Quality of life is often viewed as a secondary luxury.
Which is so frustrating.
It is. Oncologists are highly specialized in killing cancer, not necessarily in psychosexual therapy. They might feel uncomfortable bringing it up, and patients often feel tremendous guilt. They feel they should just be grateful to be alive, so asking about their sex life feels petty or inappropriate.
But survival shouldn't require sacrificing your quality of life, your sexuality, or your identity. You don't just want to survive. You want to actually live.
Exactly.
Let's pull all of this together. We started with the biological earthquake of radiation, how it shatters the DNA in the ovaries, shutting down the power grid and triggering a sudden, intense early menopause. We examined the double whammy on the vaginal tissue, where systemic estrogen starvation collides with direct radiation trauma to create dense, fibrotic scar tissue and extreme fragility.
But we also illuminated the tools available to rebuild. We demystified the pervasive fear around hormone replacement, detailing the specific pharmacokinetics of how low-dose local vaginal estrogens work safely, acting as a targeted eyedropper of moisture.
We looked at the critical necessity of mechanotransduction, using dilators, vibrators, or regular intercourse to physically signal the tissues to remain flexible and fight off stenosis.
Right.
And most importantly, we highlighted that biological fixes must be paired with open, vulnerable communication through a biopsychosocial approach to true healing.
Because the ultimate goal isn't just a cleared scan. It's the full rehabilitation of the patient's body, mind, and sexual well-being.
It leaves you with a really provocative thought. Think about orthopedic surgery for a second. If you go into the hospital for a total knee replacement, rigorous, painful physical therapy isn't presented as an optional luxury.
No, not at all.
It is a mandatory, heavily monitored, completely normalized pillar of your recovery. Without it, the joint freezes up with scar tissue and becomes useless. So if vaginal dilators and localized estrogen are just as mechanically and biologically crucial for post-radiation recovery, if they are the exact things preventing the tissue from physically freezing up and tearing, why aren't they discussed with that exact same routine normalization?
That's a great point.
Imagine a future where sexual and pelvic rehabilitation isn't a taboo subject awkwardly whispered about as the doctor has their hand on the doorknob. Imagine it as an automatic, celebrated, fiercely funded pillar of every single cancer survivorship plan. We know the treatment is an earthquake. It's time we stop just congratulating people for surviving the collapse and actually start handing them the blueprints and the tools they need to rebuild their landscape.